Right. Well, that's what I'm saying. So they're not having to, so if it's self-pay, they're not at risk. There's no risk for them. They might be taking less money.
Exactly.
Right. They're taking less money, but there's no risk. And then through, like, for example, through the telepsych, that's where the subscription fee is helping cover that gap because there is a large percent of self-pay. In the primary care, it's not quite as large, but we've been very lucky to have the MAP funding, as Chris explained.
Yeah, go ahead. I think we have time for 2 more questions, and then we'll switch to Roy. Yeah.
Program
and if you could repeat the question for the person.
Sure. Okay. The question, and I'm guessing you're talking about for the telepsychiatry, is how do we provide, or how do we plan to grow the provider base to support this large state initiative? Well, we plan on working with hubs of providers. So, for example, Mission, Brian's on the call. We've been having conversations with Mission about using their providers and creating a hub in the West, just like we kind of already have developed in the East. So that would be one way, is generating new provider, working with existing provider groups, but generating new hubs to serve geographic regions. And then the other thing is we've been in discussion with some other providers. The provider group that we've been working with in the East still has capacity. He has 3 offices, actually. We're only tapped into 1 of his offices, so there's still some capacity there. But it's a component of the project is growing that provider base.
And I think that might be one of the largest issues is capacity. Wherever there is capacity, there's an opportunity for those providers to join the project and make use of that capacity, fill that capacity. The problem is there's not a whole lot of capacity around the state when you really get down to it.
So what's been really beneficial for this practice is I mean, they folded this in with their work, with their, you know, they already see patients face-to-face in Jacksonville. And so now they never have an issue with a no-show, because if there's a no-show, that provider's seeing a telepsych patient. So they've been able to become really, really efficient and maximize their practice and see, you know, basically the full range of patients because they're always funneling. So they have someone that pretty much just coordinates all of this in their practice.
Let's take one last question, and then we'll move. Sarah? How many county investments?
Well, the reason I struggle with that question is we're the ones that have not been highlighted just have not contacted us. So there's not been a closed of the door. I mean, they can still get engaged. The goal would be that any hospital that needs it would have it by the end of that, whether they're served directly by us or whether it's indirectly through another program that's in existence that we're linking. So that's why, you know, I would imagine by the time we get to the end of 2016, I sure hope that there's a color on every county in that map. It just may be a different color based on who's serving them. East Carolina University. Mm-hmm.
All right. Thank you, Sheila. Yeah. Sure. Go.
Just introduce yourself and who you're with. Hi, I'm Lynette Polson, and I'm the Executive Director of Local Health Director.
Jason Bates, North Carolina Association of Free Clinics.
Welcome. And then, folks on the phone, I forgot to ask you to introduce yourselves. I'm going to say your names, and I can repeat it if the room can't hear you.
Sure. Hi, this is Tina Martanda at the Duke Endowment.
And Mika Sales with the Duke Endowment.
Brian Arkwright with Mission Health System.
And Kim, are you on? You might still be on mute.
And I don't know if you can hear me, but Lisa Galloway with the Division of Mental Health.
Yes, hi Lisa.
Hi.
And Kim Schwartz is on.
She was.
Or she was. Maybe she's left, but she'll come back. I'm just going to scoot this on over here to Roy, since he's sitting next to me. And Brian, just a heads up, you're up next after Roy.
This will be short and sweet because Sheila pretty much updated everybody on what's going on. But from the state's perspective, there is the funding, in case people don't know, is this fiscal year, there's $2 million appropriated. Next fiscal year, 2014-15, there's $2 million appropriated to seed this project. We have a timeline that is part of the plan, and if anybody's interested in the plan, please get a hold of any one of us, and that plan is public, and we'll be glad to send it to you. But there's a timeline involved in the plan, and the project is on time, on that timeline, if not ahead of the timeline. Contracts have been executed between the state and ECU, and ECU is now executing its contracts to move all of the current 18 hospitals that are in the Albemarle Foundation project to the ECU project. In fact, those contracts were just sent out, I believe, last Friday. And Dr. Saeed, who leads the project from ECU, has identified the folks at ECU that are going to be working on the project, as well as Sheila and Phil, of course. And I believe we are on task and on time to implement the first 2 new hospitals under the project in January. And the first 2 will be Lenore Memorial and Nash General will be the first 2 right after the first of the year. And that's pretty much it, adding to what Sheila has already said. So I'm going to cut myself off, which is very unusual, but I am.
Do you want to take a question?
If anybody has any, please let her rip.
When you make about new hospitals, where is the place? How affordable it is?
Well, go ahead, Sheila. You want to take that?
Certainly. Equipment, mobile telemetry, partly we saw, and figured on-site and set up as part of the equipment purchase. Now, priority is for telepsych. For example, right now at the hospital, there's a program operated in collaboration with pediatric teleaudiology. So there's travel and month-old infant, a family, go to the Albemarle Hospital.
And from the state's perspective, it is absolutely our intention that this is a foundation to expand for other disciplines, and any technology that is going on top of this for data sharing is also foundational in its creation. So the intent is for it to be used for other specialties. Absolutely.
All right, thank you. We're going to move on. Brian? Oh, sorry. Thank you.
Can you hear me?
Hang on, Bri.
Got one more
All right.
question.
I'm new to the process.
Jay, can you hear me?
Yes, you're on, Kim.
Good, good.
Thank you.
Okay. I know what I did. I knew what I troubleshooted. Thank you. I've been on all along.
All right.
So just in cost, got a cost site, got an incremental bit of the equipment that would need to be replaced every so often. Got the cost of the provider at the cost of the
Well, for telepsychiatry, average initial visit is about $114. Well, what we're paying for that visit to the provider is $100. And then primary care, your primary care, and it's based on your E&M code, 90% of what your Medicaid rate is. That's what we discussed.
Yeah, I was thinking not the charges, but the actual cost. So got a certain per hour cost of site.
Right. Well, for the telepsych, that's sold into the. They're not bringing on a separate nurse for that. They're just using personnel. So the only additional cost, immediate cost, is at $114. Let's say for the initial assessment. When the equipment's purchased 1 year full maintenance, on these parts, actually, service agreement, $900.
Department's perspective, question, contract, work on that, the subscription fees, uninsured at the end of not the end. Build that next foundation.
Great. I think we need to move on. Can you hold your question? Okay. Brian?
Yes.
Oh, okay. We're ready for you if you're ready.
All right, I'm starting my stopwatch at 7 minutes.
All right.
I'm ready to go.
Thank you.
You guys see me in the video too?
We can see you.
All right.
Great,
Well, thank you very much. What's that?
Go ahead.
Thank you very much for having me. It's a pleasure to present to this group and hearing everybody introduce themselves. It's a very large group, so thank you again for having me. There's my contact information if anybody has questions afterwards. I am going to go pretty fast through these as I practiced last week and we were a little over, so I sped it up. The first slide are our services for the Mission Center for Telehealth. We have Telestroke. Currently live at 8 hospitals, and we are working on our 9th hospital currently to go live over the next couple months. And InTouch Health RP7 robot is right there on the right, and that is what we currently use for both our Telestroke system and our Telepsych system. Our Telepsych system is at 3 hospitals, and we are working with both Roy and Sheila to work with the statewide initiative, and we ideally will hopefully be expanded to more of our member hospitals within our system in February or March. So we are working on those plans now and discussions currently. The next service is pediatric telepsychiatry. We have 1 clinic up and running. We also do pediatric nutrition and genetic counseling all at that same outpatient clinic. The second to last thing is telebariatrics. We're working on a current program that will hopefully be live over the next month. We have a brand new weight management clinic here in Asheville, and we're working to connect other hospitals and locations with a endpoint at their site to have some of the pre and post-op work involved with the bariatric surgery patient. The last line there is remote home monitoring, which is something we're really focusing on over the next few years and well into the future. The device shown in the second picture, as well as the device shown on the left of the picture, are the CardioCom device that we are using with inpatients who have a primary diagnosis of COPD. They will be going home with a device, and we will be monitoring them. This is a 6-month pilot, and if it goes well, we'll be looking to expand in additional applications in additional homes and across additional diagnoses. The last thing is there is Lifeline. We also have over 600 patients in their homes in Western North Carolina who have Lifeline devices. Lifeline's kind of like a life alert button that calls a first responder or EMS if someone should fall down. Next slide are our locations. In addition to our current sites, I wanted to make a quick note that number 12 in Jackson County is Harris. We just went live there as our 8th Telestroke location. And number 10 is Highlands in Macon County. We are working on implementing there currently. And then the other numbers are just other locations that we are in current conversations with and are across varying programs and development. I also have a note about Care Partners there. We recently, Mission Health System recently made a partnership with Care Partners. Care Partners is a rehab, home health, adult care, and hospice and palliative care company, organization, and we are looking to do a lot more with that. We're very excited about that relationship. And they're one of the ones that we're partnering with for the COPD pilot with the remote monitoring device. Let's see here. Next slide are outcomes. Telestroke, we are currently able to treat 35% of patients who have a telestroke consult with TPA. This is typically a 40% increase across the current spoke sites. And then you can see there that we're able to provide a mission neurologist 24/7, 365 days a year, and our average response time is 18 minutes. And 50% of telestroke patients are able to stay at that local hospital and receive care there. For our telepsychiatry outcomes, over 50% of our patients were able to cancel the involuntary commitment. Sheila went into that a little bit for their program, and we have been able to avoid 157 ED holding days per year through that program. Next slide is financial sustainability. We have calculated for FY14 a 24.8% ROI for overall Mission Center for Telehealth. That's all costs, all revenues, all savings calculated together. And as far as ROI analysis, reimbursement analysis, and standardized reporting, these are things that we have to be very diligent about constantly. We're constantly tracking them, reporting them, sharing them with leadership and all key stakeholders involved with the Center for Telehealth. The next slide are provider ability and policy barriers. I just had two notes here. You have to be very cognizant about when you're starting to develop a new program that you kind of take into account the different readiness factors that are important for success. These being physician champion, administrative support, clinical capacity, operational logistical complexity, and clinical value. If you're able to kind of line all these things up, you're going to have a much better rate of success with a new program. The second is environmental scanning. The policy barriers have really come down over the past couple of years, and I think it's important to have a constant scan of the environment, knowing successes and failures across different systems, and being diligent about collecting and looking for those revenues and reimbursement. The question that we were asked is, where will rural patients and health systems get the most bang for the buck? Telepsychiatry, I think, is first on that list, then telestroke, then remote home monitoring. Redesigning home care, I think there's going to be a lot more in the home that we're able to do with technology. And schools, I think there's a lot of opportunity with schools. The next slide is, what should we all be thinking now? I think regional needs and really meeting those. Readiness factors, let's apply all these different things. My 7 minutes is fastly approaching, so I'll wrap it up. Sound development approaches, kind of really thinking of it as a process and redesigning something that's maybe not a ideal process to something that's more efficient, gets better access and is lower cost, and produces a better outcome. And you must have key stakeholder buy-in across all areas, from leadership down to front-level staffing, physicians, and patients if possible. And then infrastructure is important, being able to carry out day-to-day operations and management. Funding sources, lots of grants and foundations as noted on these calls. And business planning, I think it's important to approach any new program with the same level of criteria that you would with any business plan, making sure that it is sustainable and has a strong, valuable component and outcomes and high quality to the health system and to the region. And that's it.
All right. Thank you, Brian. I love that you were your own timekeeper. That's so helpful. That's so helpful. I think we have time for one or two questions, if there are any questions for Brian about how Mission is using this. Yep. Behind it, yes.
And actually, this question about all the telepsychiatry, you say mental health follow-up after the evaluation assessment. How is that played out, and how is the primary care? So if they're prescribing medication, that telepsychiatry, what's happening afterwards to monitor action?
Brian, could you hear the question?
Slightly. There's some slight
I'll repeat it, and Kathy, tell me if I'm missing anything. So Kathy's asking, for telepsychiatry projects, if you do a consult while the patient's in the ED or in the hospital, but then what's the next step to link that next step mental health provider back to a primary care for the patient? Is that right?
The follow-up, the monitoring.
What's the follow-up and monitoring that happens?
Especially medication.
Particularly for medication management for telepsych. Sheila, do you want to answer, or Brian, you want to answer with what's going on in Mission?
I mean, currently we're, directing those patients to primary care and outpatient clinics and other mental health support where possible. They're also linked into the LMEs and that kind of support as well. That's probably the best I can say to that. Sheila might have more, somebody else might have more.
As you can imagine, it's hospital specific. And certainly if this is an indigent care patient, you're connecting them through the LME, help find what resources are there. But it's so different community to community. We do go into a new community, we try to work with, we look at the databases that the LME and MCs have, and then we also look at the yellow pages and try to work with emergency departments by what the provider base. And some of them, we've actually been able to do great education of the hospital emergency department staff to let them know there were more services than they realized. But in other communities, there's not a lot of service.
And how do you make sure it gets done?
That we are not making sure.
I mean, you've got your readmission rate. That's the one thing I can see.
Right.
Otherwise,
hospitals are doing a much better job than others. Albemarle is kind of our poster child because they have dedicated the resources. It's part of the protocol that a nurse is going to make that. Every hospital hasn't latched on to that, but I think by in the future where it's going to be out there, it will help trigger that needs to be happening in some hospitals. But then again, it's going to reflect what's in the community, I think, not just what the hospitals do.
Okay. Thank you, Brian.
I got one other question.
Thank you.
Yeah, wait a minute. We have one more question for you.
I know they have the National Health Information Exchange in Western North Carolina. I'd like to understand, how they're integrating an information exchange with telehealth applications. It's about integrating as well as it is about care.
So, Brian, the question is, are you in any way integrating your information into the Regional Health Information Exchange up there in the West? How is that happening?
I know we are tracking any consult that we do into our EMR, EHR, and I am kind of peripherally involved with the Regional Health Information Exchange as well as the, I believe Mission's doing their own as well. So we are coordinating with kind of through the EMR to make sure that information is shared just the same as a face-to-face interaction.
So Brian, Steve's offering to answer that question in the room.
Yeah.
There you go.
Sorry, Brian, I actually know a better answer. There is currently the Western Carolina has a data link, WNC data link, which has primarily lab data and imaging data that is shared through multiple hospitals. I think that there are 16 total that are not through an affiliation. Mission has developed their own more robust internal HIE that is now just being used with hospital-owned practices across the region and hospitals themselves. And we'll begin to add additional programs. But at this time, there's no real integration into the telehealth networks. There are very few places where telehealth and the EMR are well integrated. And that's just an ongoing challenge. These two technologies sort of, from my perspective, are going down parallel pathways, but really don't talk to each other very well. Yeah.
Or even where the practitioners using the telehealth are accessing the RIO to complete their information about that patient. That patient could have been admitted tomorrow last night.
And the RIO may or may not have that level of detail.
Right.
Yeah. Yep.
So we've identified a challenge that we're going to skip as we now move on to Skip and Tom. Do you want to switch places with me? Or you? Okay.
It's Skip's
we'll
show.
Skip to Skip.
I'm just going to sit.
All right.
Oh, since when?
Not a chance. You are one to talk.
Thank you, Brian.
Again, I'm Skip Cummings. I'm from East Carolina University, and I'm speaking really on behalf of Gloria Jones, who's our telemedicine program developer and coordinator, has been there for a number of years and has really lived through the development. And the one message I want to make sure you understand about the work at East Carolina University is that we've been doing this for a fairly long period of time, 21 years now, of telehealth applications. And as you can see from this early slide, this beginning slide that Gloria put together, we've been mainly focused on Eastern North Carolina, which is obviously the region that we're trying to provide care for. But we've also dabbled with how this system might be used to connect with other places, both across the country and even around the world. One of our infectious disease experts doing a consultation along with folks from Hopkins to Ethiopia and dealing with some difficult HIV/AIDS cases in Ethiopia. So it just gives you the idea that once the equipment is in place, you can, the possibilities are absolutely limitless in terms of what you might be able to accomplish. Well, it doesn't seem to. Oh, okay, there we go. All right. So on this slide, just want you to get a sense of that history, that our 21st birthday there. Somebody can take us out tonight. We really started with, just some efforts to link to the central prison. We found out that it was early in those days, it was very expensive to take a prisoner outside of the prison. Still is. Have two guards to go along with them, and just a lot. And so we created this relationship, and actually that relationship still exists. And you see some of the expansion.
The box cost $50,000. Each box cost $50,000.
In the beginning.
And we had that one contract, and I had to go out and beg doctors to participate because they didn't want anybody in the prison ever to show up near them, even if it was on television. It was a strange time then, very strange time.
Obviously, that's grown. You see the little map on the left, and even that is incomplete. It's a year or so old, and we're in a variety of other places. You've heard about the telepsychiatry program and how that's greatly expanded in our region. And you can see that we've connected now with some residential schools, the School for the Deaf, and other places around the state. Again, kind of like the prison model, where it's very hard to have folks move and get involved with other things. So, and these are just sort of the categories of some of the ways that we've been involved, mainly around teleconsultation and specialist care. Again, thinking about rural Eastern North Carolina, a lot of primary care providers out there, but very little specialist care east of I-95. And so we've been able to reach out using telehealth applications to a number of communities in our region. Obviously valuable in terms of distance education and piping all of our grand rounds and other things out to local providers, and then connecting with patients in a variety of ways through multi-specialty consultation as well as patient follow-up. Here you see the list of applications, and again, almost any specialty you can imagine we've dabbled with in terms of providing care out in the region. We just recently was talking with Gloria, and we have some stroke patients out in the region, and there's no physical therapist anywhere near. And so we've begun to dabble, for example, with stroke rehab over telemedicine. So things like that, it just is a necessity. It's a need, and we're trying to look at ways we can use this technology to improve care outcomes. You see there on the right, one of our pathologists. And so this is the telemedicine suite. We have a whole separate area where we have several of these small telemedicine suites where a provider can go in and link with an outlying site and use all of the technologies that you've already heard about, stethoscopes and other things, dermatologists looking at, lesions far away, et cetera. And pediatric cardiology has been big, telepsychiatry you've heard about. So lots and lots of experiences in lots of different areas. One of the biggest recent ones is now dental medicine. Our School of Dental Medicine has jumped on this, has been really excited. They've established, or are in the process of establishing, 10 different places around the state where their students will go in practice. And they've invested the funds to buy this equipment so that their students can be precepted remotely from Greenville while they're out in practice in one of these remote locations. We also have a van that's working with, go back there. Have a van that's being used to work with military, so high concentrations of military families who don't, again, maybe have good access and need specialty care. We've used a van to get to some of those folks, and we are, along with Vidant, exploring some of the same home applications and telehealth monitoring. This is sort of my shtick in this. We've just, thanks to Jay and KB Reynolds, as well as the Office of Rural Health Policy, we've gotten involved with diabetes care. The idea that, again, there are a lot of diabetics out in the region who don't have access to the full range, if you will, of diabetes services. And our great concern is that many of these folks have substantial comorbid disease, and in a busy 10 or 15-minute primary care visit, it's very hard to manage those. And so we're putting a psychologist, a nutritionist, a pharmacist, and a nurse in front of the telemedicine unit in Greenville and linking to 7 primary care practices to help them with their more challenging diabetic patients. So we're looking forward to seeing that get geared up. So that's really my shtick. Tom, anything you want to add?
Oh, it's been it was interesting being such a pioneer in this, and we only found out after we were the pioneers that they'd already been to everybody else and asked, and they'd all said no. That is, Central Prison had been to everybody else in the state, and they'd all said no. So we naively said yes. It stuck us a little bit. We got stuck with the very expensive early equipment for a while. That wasn't real functional. It was a jerky connection and that sort of thing. And when it came time for us to grow again, it was in, I think, the recession of 2003 or sometime around that, 2002, and we weren't about to grow. So we got stuck a little bit and didn't get to, in a way, by having been in the game early. And I think the other thing is that we got pretty much fixed in this one model of telemedicine versus the other kind of telehealth applications that can be used. For better or for worse, it's what we got. And so I think we lost some of that. We lost what I think we could have perhaps been over time had those things not happened to us. But I told everybody in this group the last time we met, we were talking about this. The funniest story was we went up to Raleigh to a big signing of the contract with the prison system. Up there at one of those clubs, the Capital City Club, the two that recently merged up downtown, you know, and all these prison officials were there, and I signed for the school, and I was there, and the former foundation director at the school was there, and then there were these 7 people from the prison system, and within 1 month, all 7 of those people from the prison system had been fired. All of them for criminal corruption, which related to the purchase of large numbers of items of clothing and tennis shoes and things that were much too large for any human being to wear for the prison system from some relative or friend of somebody. And I thought we were in real trouble, and we weren't. We survived the audit, and we looked real good. And then the foundation director got caught with his hand in the kitty at East Carolina and went to prison for that. So the only one that's left is me. And I'm just waiting for the next shoe to fall.
I think you're safe. Questions?
I had a question about the military families, TRICARE, payments, sustainability, part of the solution. What's your biggest challenges for all that?
Yeah, I wish Gloria was here that could really tell you more about how that's connected with the military bases, but I think there's a lot of concern about, again, not enough specialty care in those military bases, and so it's really, while they have the primary care on base and stuff, they don't have the linkage sometimes to the specialty care. So I think TRICARE, you know, should be willing to invest in that.
Whether they are or not is a different story.
Mm-hmm.
All right, thank you, gentlemen. You can ask the question while we're switching around. And Steve, you want to come on up?
Yeah. What is basic upfront cost for these expected lives? Home rule practices aren't necessarily that great at enabling and capital structure can get a little moldy. So I'm just wondering how long, once the grant, whatever starts, how long can you expect in the past and at what point practice pop up projects or?
I can give you off the top of my head my response from the depends a bit, the cost of but additional applications, stethoscopes, otoscopes, and et cetera. But the basic equipment that is around $10,000. The nice thing is that it's entirely encrypted. Basically, HIPAA point. I think, one of those units had a number of them in service for around 5 years.
So yep, Steve can go ahead and answer this question.
Sure.
As he gets
Andrea,
started.
the Ontario Telehealth Network, which is the world's largest telehealth network with close to 5,000 unique sites that they serve, has equipment that has been operating for 10 to 15 years, that they continue to make sure that as they build up their infrastructure, those units can still connect back. So, yeah, the durability is pretty darn good, I believe. Yeah.
Go ahead and start and introduce yourself, please.
Great. My name is Steve North, and I wear a bunch of different hats, but I am the medical director for outpatient telehealth at Mission Health. However, this program, the My Healthy Schools program, is a program that I started working on 6 years ago when I was selected to be a Jim Bernstein Community Health Leadership Fellow. And school-based telehealth is one of the great areas for...
Is it working?
No.
Keep talking.
Yeah, I'd love it when the technology guy can't get the technology to work.
There you go.
So school-based telehealth is one of the really great opportunities I see. And our program is unique in that we started as a grassroots organization and have worked over the last 6 years to develop a program that now reaches 4,000 kids at 14 schools in Mitchell and Yancey County. Mitchell and Yancey County, for folks who don't know their Appalachian geography very well, is located halfway in between Asheville and Boone, right on the Blue Ridge Parkway, and west from there. And our schools range in size from B-Log Elementary that has 60 kids and is about a 25-minute drive on a good day from the nearest healthcare facility to high schools around 500 to 600 students. It's a relatively small district, a set of 2 districts, I'm sorry. And so school-based healthcare is something that I actually went to medical school to do. I was a Teach for America Corps member in the early 90s in eastern North Carolina in Edgecombe County, and went to Chapel Hill and spent some time in Rochester, and am very excited and continue to be very passionate about this idea. So meeting kids' needs for care at school, where they spend the majority of their time, has been shown to both improve health outcomes and also improve academic outcomes. Clear evidence shows that school-based health centers decrease inappropriate emergency room utilization and increase mental health screening. All right.
Thank you.
Now we'll see what I talked about. The slides don't match up. So school-based health center outcomes help kids access care more readily and have been shown to have a clear reduction in Medicaid expenditures. Currently in North Carolina, depending on how you count our network, there are either 55 or 65 school-based health centers. And the academic successes all really focus on increasing seat time, helping kids graduate, and improving their GPA. So in our rural community, it's not possible to place a nurse practitioner at every school every day. And in addition, small schools like B-Log, pictured here, only have a nurse 1/2 day per week. So the My Healthy Schools network uses a standard telemedicine cart. It's equipped with an otoscope, a general exam camera, and a stethoscope. We are on our 3rd iteration of purchases, and each year the price has dropped by $2,000 to $3,000. So Our first set of 3 carts was about 27 with the service plan, and our most recent set is around 19 to 20. We just brought 7 new carts online. Our program has been funded over the past 3 years with funding from KVR for operational costs, local ARC, HRSA, and USDA grants for equipment, and then also, let's see, we have 2 streams of state funding now. One is Office of Rural Health and Community Care to reach uninsured and Medicaid eligible kindergarten through 5th graders, and also community college students who are uninsured. And then we also have a smaller school-based health center grant through the Office of School Health Programs. And I know I got that name wrong. But we provide both acute and chronic care, and we are trying to become an extension of the primary care physician. Unlike Sheila's program in Hyde County, there is a relatively strong primary care community in Mitchell and Yancey counties. We're still a HPSA area. We have a federally qualified health center and 3 rural health center sites. But trying to have my colleagues see this as not taking away their patients, but expanding their ability to care for the patients is taking time. And the other thing I wanted to mention, you had mentioned diagnostic accuracy around ear exams, and there's a good study out of University of Rochester that shows that that diagnoses using telehealth for pediatric diseases is equal in-person to examiners versus a telehealth examiner and an in-person examiner. So we're definitely not providing a lower standard of care. So as we're now in every school in Mitchell and Yancey County, and our utilization numbers continue to grow, we're starting to look at the potential to expand either our own network or share this model across the state and across the country. CRHI, myself and Amanda Martin, who's at the School Nurse Conference right now, consult weekly with regional and national groups trying to implement a similar program. And we know that right now in the state of North Carolina, to meet the needs of our uninsured students, we would need another 186 school-based health centers. This may be one way to spread our model or spread access, improve access to care, I'm sorry. We're looking at expanding specialty services. Right now we're working with Mission Health, and we'll have child psychiatry available within the month. Behavioral health service has been difficult. Western Highlands was not willing to explore certifying our network as a provider for mental health services. We are also working with East Carolina and Greg Cummings. One of the dental clinics is being built in Spruce Pine, and we're hoping to actually use that to link out to our schools. We also have good reimbursement in our state, receiving both Medicaid and reimbursement from Blue Cross Blue Shield at this time. So the challenges to expansion: high startup costs. How do you balance the role with school nurses? We have a great relationship with our school nurses. I'm co-presenting the plenary tomorrow at the School Nurse Conference with Yvonne Harden, who's the lead school nurse in Yancey County, talking about this very issue. However, Yancey County has 8 schools and 3 school nurses. So at BLOG, Karen's only there a half day per week. Who can be the other telehealth presenters? When we initially started the program, both districts said very firmly, we only want our school nurses to do this. And now that's a cap to, that's a preventing factor to our growth. And so we're working on that. Growth curves across telehealth, there's not great information, and especially in the school-based health area. And we're continuing to work on the integration into community care. So, thanks. I didn't time myself like Brian, and I could talk forever like Tom, but here's contact information for me. We're on the board of, I'm on the board of the Mid-Atlantic Telehealth Resource Center, and through that organization, CRHI has a subcontract to help rural programs set up telehealth programs, can provide up to 10 hours of complementary contracting for folks in the Southeast and Mid-Atlantic.
We probably have time for one question, if there's one question for Steve. Or we'll just move right on. Thank you. Thank you very much.
Thanks.
So can you introduce yourself and the folks on the phone?
Sure.
Who you are?
Sure. Do I change the next?
I think you're, yep.
Great.
Yep. Cool.
Hi, folks on the phone. I'm Josh Alexander. I'm the Director of Pediatric Rehabilitation at the School of Medicine. About 1998, we founded a program called Telebility, and we'll tell you about that today, how it might be able to grow to serve our state and across the country. This is the population.
Is it working? There you go.
This is a typical patient that we see in pediatric rehabilitation, the child with cerebral palsy who has multiple care providers, who has to come back and forth to the hospital. You know the story. I'm not going to say it again because the folks here, I think for the most part, know about these patients. Our patient population is about 55% Medicaid, 10% no pay, and the rest a mix of Blue Cross Blue Shield, private pay, and TRICARE. Before I go further, too, I just want to let you know, when I look at telemedicine and telehealth, I look at it more as an issue of social justice. It's not about catchment areas. It's not about, this may be the folks in the hospitals you have to convince. They want to get their catchment area increased because they want more incoming, more downstream revenue. To me, it's an issue of, just like food insecurity, this is information insecurity. And for people who are in the rural areas, they may not know it, but they have that information insecurity. And the goal for me for telehealth, not just telemedicine, is not just to provide the service, but you also have to educate, support all the providers. So this program is a little bit different. Again, it's based the same thing as I think everyone else here in the room. We want to save people the traffic, the time, the windshield time, and go across the state. So we had 3 goals initially. One was to connect people in different locations, again, to increase access to specialized services. At the same time, though, we wanted to train those providers in rural areas so they do not feel isolated, to be the only occupational therapist in this one area, the only PT or speech language pathologist in this area. So from a multidisciplinary approach, we want to provide services to families and also educate the providers. Goal 2 was to serve as a resource for credible, reliable information through websites, through chat rooms. In fact, we do threaded discussion list chat rooms, which we haven't done anymore, video conferencing, educational video conferences, et cetera. And the last one really is to leverage resources from across North Carolina. So even though this was based in at UNC, this is not UNC-centric. This is not a hub and spoke. It never was, and to my opinion, it never should be. It's got to be, you take the expertise and leverage resources so that if you're in Greenville and you need somebody in Boone, you get that person in Boone. So wherever you are, leverage those resources. It's not just providing services, it's providing and receiving services simultaneously. Funding history, we started off at UNC in 1998. Dean's office gave us some money, AHEC gave us $20,000. Health and Human Services gave us money. We had initially grants, largest grants from the Duke Endowment and then the John Rex Endowment for Wake. We built for our video clinics. We also had, because of that, our Wake Telehealth Center started up just fundraising run, walk, and roll, and it's grown to about $40,000 each year to get. It helps. The programming has been over the time. It's not just the telemedicine itself. It's been website content, an expertise directory, which I think you can use for mental health services and other services, a listserv, newsletters, which we're no longer doing because of lack of funds. Our educational video conferences also, unfortunately, are no longer being done because of lack of funds, and we still do our multi-point video conferences. Locations that we've had over time, you can see some stars out in Asheville, in Wilmington, Chapel Hill, Durham, a big one in Wake County, as well as in Greenville, and I forgot New Bern. But because Wake itself, we looked after our first iteration of these large centers. We thought, we shouldn't actually have folks have to come to large centers. We want to drill down to where people live. So what we did was place units in inclusive child care centers, in residential care facilities, for service program locations, state agencies. These are where the kids come and their parents come all the time. Like school, they're there all the time. This is where we should serve the people. Even if you have to go down the hallway, and those folks who have to ask doctors to come do telemedicine, if I got to go from one building to another, I'm less likely to do it than if it's in my clinic or in my spot. Same thing for receiving services. The parents drop them off somewhere. That's where the children should receive the services. And what we try to do is to build a community of practice. It's just a group of people who share a common concern or set of problems and work together. Regardless of where the location was, we had sweat equity, so in order to be able to participate, you also had to provide services, educational programming, your expertise, telementoring, and oversight. just 10, again, this is just in Wake County area. We've had about 6,000 people in different video conference sessions, mostly the educational ones. We've had our people brought in from across the country, from across the world to come and talk to us, so we don't have to pay for them to come and travel, have the time in the hotel. They just do their video conference and then they go away, so it's a little less expensive for us. I know it's a Likert scale, 5-point, you're going to get a 4 out of 5 most of the time, but just bear with me. Satisfaction and comfort level was okay for providers and participants. This is just in Wake project in the last, it was 3 years. 1,300 people, travel cost savings, 55 cents a mile, we just did it that way. A number of hours, again, looking at through Google or usually Google Maps and looking at that for length of and distance. Travel savings. Again, this is video clinics, a smaller number, but again, to save people time and effort. So overall, the video conferencing applications that we've used, the video clinics, consultations, telementoring, educational programming, networking, so families can help, so professionals can help with each other, parent support, and of course, don't forget about you still have those boxes. No reason your administrator should be moving, across the state or other places to have these conferences. You should have it one place where they're working. So what's up next for me? Well, I've kind of gone from the big room and getting smaller and smaller and smaller. So just some philosophical approaches. I think the future of telemedicine and telehealth is in the home. And I think we have to figure out ways to get there credibly and reliably, safely, obviously. But we have a little grant. This is the Google Data Factory, some support in Lenoir in the Caldwell County. And so they've given us a little bit of money to work on combining early intervention services, therapy services, and medical services directly to patients' homes in Caldwell County. So that's just a thought. I think the program we've had over time, I'd be happy to show you the directory of resources that we've established in Wake County and other places. There's no reason it can't be applied to any other condition, mental health services, any other age group or whatnot. But to me, my bias is don't make the repository of information for just the providers. It's got to be out there for anyone. Providers, care coordinators, the parents, the patients, everyone should have access to it because the more that they know, the more they can work the care, the better. Okay.
Take a question?
Yes.
And then Kim, you're up next.
The directory is a static directory, so it's not interactive in any way. Is it?
Yeah. So no, it's not PDF. No, we would never do a PDF. So, for example, in Wake County, if you want to go, for example, in Wake County, you can say, I have a child this age with this condition, with one of 20 or 30 different needs I have, Spanish-speaking therapy services, and I live in this part of Wake County. Push a button, and it will give you a list of at least 10 to 15 providers that provide just those services for you just in that part of Wake County.
So is that directory available only for Wake County, or you've got that for?
We only had money to do it for Wake County. Okay. There's no reason we can't. I'd love to be able to do it statewide. The key is you can't just have, and we've got in our main website, in the directory where you can search the entire state for areas of expertise, or therapy provider, type of therapy, or by location. But there's no reason you can't drill down more, and I think it would be better to drill down more using those resources and more direct locales. Excellent question.
Great. Thank you so much. Appreciate you sharing the information.
Oh, sure.
That's great. All right, Kim.
Yes, ma'am. Can you hear me?
Yes, last but not least.
My video was working, and I'm not sure why it's not, but can you hear me okay?
We can hear you fine. We're trying to figure out how to advance the slides, so hold on just a second.
Okay.
Hi, Kim, at the top of your screen, you'll see the number and the slide, and to the right of that will be the arrow that you can change.
It's as simple as it was in practice. Okay, got it. On pages?
Right, so you just click the right arrow.
Go to the next page. Got it.
All right. Great. Okay. I'll give you your, you're not here to see my little sign, so I'll give you your warnings over the phone. Thank you.
Try to monitor myself as well. Hello, everyone, and I apologize for not being there. This is one of those times I wish I could be two places at once. My name is Kim Schwartz, and I'm the CEO at Roanoke Chowan Community Health Center. That's where we are, and you know all about that stuff about northeastern North Carolina. So our project has been in existence for 7 years, since 2006, and we were initially funded by the Health and Wellness Trust Fund. In fact, we were in their first year of funding. And our focus is remote patient monitoring strictly. That is the only portion of telehealth that we do based out of primary care provider. So the relationship is between the patient and the primary care provider, and we do a hub and spoke model with us in Ahoskie being the hub and spoking out to patients' homes and our partner sites. So those are our partners. The HRSA OAT grant we received in 2010 and finished up in in August of this year, and the same with Off Rural Health. I actually ran that grant from 2006 till 2013, and some of our published outcomes of that are well published, and you'll see that here in just a minute. We impacted over 19 counties in North Carolina, embedded in multiple partners, so that was very, very cool to be able to do that. And our next those projects both have ended, though, in North Carolina, and so we don't have a current project in North Carolina. We do have a project, though, in that we were just recently funded, saying that Skip and his team was funded for that same project. Only 6 projects across the nation were funded, so proudly 2 of them were in North Carolina. Our project, however, is based in Oregon, with the Central Oregon Telehealth Network program there, and that's the COTN. And what we are doing there is working with OCHIN, which is the Oregon Community Health Information Network. And at Roanoke Shawano Community Health Center, we've been a member organization of OCHIN for going on 3 years. And OCHIN has over 60 partners across the nation that are primarily community health center partners, so it's a HRSA-funded network. And they've been in existence since the late 90s. And they use Epic. And so, of course, our major partners in the state transitioned to Epic over the course of the last 5 or 6 years that has to be Biden. And we were looking for a partner that we could have that interoperability consistent. So we were able to hook up with a group out of OCHIN called Mosaic. And Mosaic is a Central Oregon based out of Bend, and then they have 5 sites that are rural designate sites. And along with the Central Oregon Health Network. Now, they are, Oregon, as some of you may know, are one of the states that was modeled willingly to be for the Affordable Care Act. And so the Central Oregon group is an ACO, and they call themselves CCOs out there. And so it's the Bend, Oregon base. So our partners in this are basically the ACO. And we wanted to use this model to be able to demonstrate the cost savings and the value proposition of using remote patient monitoring based in the primary care, but integrated out through the network in year 2 and 3. And so that not all of them are Epic, and so we needed a partner to bring into that could help us do the interfaces, the data integration, and so our project is actually with a public and private partnership. So it's InScope International, which is primarily a group that works in defense and energy, and they're software-based analytics, and so they're going to build a product that can be across all these sectors, including CMS, so that we're able to get financial data. That was one of our barriers in both our HRSA and our Off the Rural Health grant. We were not able to get financial data that was consistent to be able to demonstrate costs through the whole project. One of the other really, really unique and wonderful things about this project is that it's also a partner with Matrix. Before I go off of that, let me mention that we're working with Centera PACE, and I'm actually at the National PACE Conference now, and Western Tidewater, both out of Virginia, on 2 telehealth projects there that are remote patient monitoring based out of their projects are centralized. So through 2 of those are revenue generating, and we're also working with InScope, who is doing marketing of our project out through employer health and self-payer networks, working for brokers. So we start 2 of those projects in October and November, which will help sustain our project. So before I move on to the network, to share a little bit more about our partnerships there. Here we go. So a part of the Affordable Care Act, those are our partners, and our Mid-Atlantic Telehealth Resource Center that Steve mentioned earlier, I'm also a member of that organization, but as part of this grant, which is going to be so cool, they're going to pay an intern to do monitoring, and they've already opened a website, and to kind of track how to start a telehealth network. integrated into an ACO and through primary care. So they're actually going to replicate through the Northwest Telehealth Resource Center and the Mid-Atlantic Telehealth Resource Center how to monitor this whole process. So we've created a bit of a monster here, anxious to see how it'll come out, but the feds are excited about it, the first time they've ever done a project that's bi-coastal like this, so we're anxious to see how that's going to come out. But I will tell you, we scored 100 on that application, so I'm pretty proud of that. You've all seen and talked about remote monitoring, and it was such a great transition to say we're in the home where we need to go. And of course, we all want our folks to age in place as much as possible, and we know that that's where they develop their social networking and all of that good stuff. So you all know that. I'm just preaching to the choir. What we measure and what we're going to continue to measure are biometric and social factors and medical costs and all the clinical indicators that focus on chronic disease management specifically. And I might mention there that in our HRSA network, we actually did a pilot. We only had 5 patients in the pilot for behavioral health co-occurring. And I will tell you that pilot was extremely successful. We reduced the PHQ-9 score, or improved the PHQ-9 score by 50% on those patients, and they were on it for about 8 months. Unfortunately, our clinical social worker that was leading that project passed away suddenly, and so that project kind of got on the back burners. But we were looking forward to advancing that, and Roy knows we've had some conversations about moving that forward as we navigate some of the things that are going on in the region. And let's see.
Kim, I'm giving you your 2-minute warning.
Thank you. So here's our outcomes. They're well published. I just can't even minimize that 83% reduction and 75% reduction and 87 decrease. And those are achievable outcomes if the project is done well and done right. I used to say that it was rocket science. It isn't rocket science. This is 7 years of working hard at problem solving and troubleshooting and lessons learned on developing a smooth program that is patient-centric and broadens the base and it keeps the communication open. I love the transition of the social justice component of it because this crosses every factor and every issue, whether it's private for pay or our patients that have issues with funding. There's some great videos. You'll get these links that there's a really one focus on patients and really one focus on providers. So I encourage you to link those. They're 3 and 7 minutes long each. How to pay for it, this is the big question all along, but as I mentioned, we don't have a code right now in North Carolina. We got really close about 2 years ago, and I think through CCNC and some things that are moving forward, we will find a type of code in this, and there are several states that are already doing it, so we don't have to reinvent a wheel. So looking forward to working with them, and I already work on the National Telehealth Association with these groups. And emerging trends, we've already talked a little bit about those. So I have to emphasize this. The vendors are out there to make money. So that's one of the things is being able to talk to folks, and they always overpromise and underdeliver. That's just who they are. And you can't do anything like this alone. All of my partners already talked about this, and as you can see, we've been funded on multiple groups for our project, and really looking forward to advancing this deeper and broader. I think I'm right at my minutes.
Thank you, Kim. We probably have time for one question, and then the telehealth piece is going to wrap up because there's another important piece of the agenda for this meeting that's coming right up. Any questions for Kim?
Jay, I can't hear if anyone's speaking, so if you could help me there.
I'll repeat it for you, Kim and Brian. Okay.
Do we have a state overall vision? Who's advocating body or whatever on behalf of? I mean, is there organized?
So the question, I'll pitch that probably to, I don't know who, Roy? Who would be the best one to take it? ECU? Steve? Who are you pointing to? Oh, Dr. Cummings.
The secretary of
the question for Kim and Brian, the question was, is there anyone in the state that's coordinating an overall vision for all of North Carolina around telehealth, variety of applications?
Yes, we've actually had 2 telehealth conferences, and I think many of us in the room were at the organization of that, and then of course through the Mid-Atlantic Telehealth Resource Center. That's, I think, Steve, am I right? There are 8 states involved in that, and we're one of those.
I need to count on a map.
So nothing separate that's just North Carolina right now, but building into a regional emphasis.
And through NCHICA, Holt Anderson has been working to develop a statewide organization. And there is a North Carolina Telehealth Resource Center website. Brian probably knows more about it because he's been on the sort of calls about that.
Yes, I'll send the link to everyone here in just a second.
Great, thanks, Brian. So it does exist. As far as a sequential plan, not that I'm aware of, we have a variety of, everybody's trying to jump into telestroke, all the big hospital systems, because it's sexy and is shown to really change lives. However, the Telepsychiatry Network is really the first statewide program. And on an individual basis, I think we as a state need to be careful that we don't end up with a telehealth unit at clinic from big city hospital A that can only be used to see their specialist, and right next to it, therefore, has to be a telehealth unit from University Hospital to see their telehealth specialist. That really defeats the whole idea. And so when I spoke at this organization, NCHCA's conference, I kind of proposed the idea that we should flip the model and have community-based telehealth centers that could link to anyone, as opposed to needing to come from a big academic or tertiary care center to fund it. So nobody's called me to explore that idea further, but we're out of time.
Thank you. We're out of time. Let me just ask Jeff to close with, you want to say a word or two about what he wrote up on the board, and then for the two of you on the phone, we're gonna shut off the WebEx, and then you've both been given the call-in number. So anybody who's on the phone, we'll shut this down on the WebEx piece, and then we'll start up the call for the next piece of the meeting in a minute.
Yeah, this is Jeff. So if you need any of the codes to sign in to the next piece of the meeting, let me know. I can give you those codes and the phone dials in a second. So first of all, can we thank everybody who did these presentations? So I really appreciate taking your time, coming here today, being whipsawed by Jay to do things in such a short period of time. Thank you, Jay, for putting this all together. We like this lightning round ideas. We'd like to do more of that in our meetings as well, so we can learn something really quick and really see a wide picture for a short period of time. So I put a couple ideas on this whiteboard here. I'll go through this so folks on the phone can hear about them too. So that I always like to say, what's the so what? So what? We just heard a bunch of great ideas and some really cool things that are going on. The question we need to ask is, so what? What's going to happen next? What are we going to do about this? I mean, and really what we're interested in is, how's this going to improve health in rural North Carolina? How can we take ideas like these and spread opportunities for improving rural health in North Carolina? So the things I heard, first of all, is I don't think anybody's really got a picture and a concept of how this all fits together. It's a bunch of different ideas and cool things that people are doing, but I don't see that I see a statewide coordination activity, that there's really opportunities for shared learning. I mean, somebody's doing something cool here, how's it getting over there? You know, how are we spreading? How do we take advantage of those things? Communication is a big deal. You know, I mean, I'm sure if I went around the room and said, were you aware of this? Were you aware of this? People go, no, I never heard about this thing before. What were they doing? I didn't have any clue about that. We don't really have a good communication tool or vehicle for funding, what other people are doing, really how to stay up to date, learn if there's opportunities for spread or collaboration. So, you know, we just heard NCHICA might be one source of that. I mean, I don't really see much flowing to me out of these ideas. So it's a great question. Where can we, I think everything, when you can centralize some of these activities like communication, making sure there's some coordination going on and some networking going on, you know, I'm not sure I know who that is. You know, there probably isn't somebody who's in charge of that. spreading these innovations, integration, we just heard a lot of ideas around integration. You know, how do we integrate the build out of the health information technology that we're doing, all this EMR integration and everything else, that needs to be integrated in here. Sustainability is a key thing. You know, do we have the sustainability models built in this? I think the sustainability has to be built in from the beginning, and again, from rural health, that's a real problem. It's always an issue about sustainability, and then there needs to be some policy development that undergirds this. You know, where are we going as a state? Where are we going in rural health? But what do we need to do on a policy side that makes sure that, you know, payments, I've heard a couple places where, well, if we got paid for this or got paid for that, maybe we could do some more. I will throw out an idea on payment. What if your health system received a global budget? Would you do this because you got paid for it or didn't pay? You wouldn't do this because it was, I got paid for it. You do it because it's a better way to do health care at a lower cost. That's why you would do it. It wouldn't come down to, do I get paid for it or not? It'd come down to, is this a better way to deliver health care at a lower cost? That's the real question. Working that idea out. So that's part of the policy development here is, you know, thinking through how we embed these kinds of things as we build out these models that are about integrated care systems with global budgets, capitated budgets, if you want to think of that. And that's where you're going to find these robust models take off, because they're going to be better health, lower cost. So I was
going to ask, I know the NCIOM has been leading a rural health strategic planning effort, and I wonder if any of this is that in those discussions around the state, or if not, if we could think about a way to encourage them to make sure there's something in the idea and the plan about how telehealth.
It is one of the, in the telehealth and exploring alternate technologies is one of the items that's in the recommendation plan. It's draft form right now. They're just finishing getting a lot of community input, but telehealth is in there. That was identified early.
I was going to say the exact same thing, Jason.
There's also a telehealth study bill that's, I think, was recently passed to a law that should be getting studied at the state level.
Okay, thanks. Thank you, everybody. Thank you again to all.
We'll send around this list in the rural group at least, and the experts that are in the room. I'd like you to also, you know, take that list and think about it and get back to us. Put your rural health perspective on, because what I think we'd like to do as a group is to stay in touch with this as an issue. You know, as this rural health plan comes down, our group, our leadership team here is going to say, what do we want to work on? What is the things that we can make a difference in? And I believe this is one area for us.
So stuff around about something Jay said is that there were lots more folks that could have potentially come and presented on what they were by the group. I mean, is there something radically different than what we heard today that's happening with things?
Not from what I found. I found a number of other, like lots of different folks doing remote patient monitoring.
Okay, so it's like models, but
similar models, right? Though I might not have heard from everybody. Every university, almost every university in the state has something telehealth going. So we could have had 3 hours just of all the different universities. But I didn't. Right. I didn't see other. I tried to get a representative group of different geographies, different patient types, different disease health issues. But others, if you all know of ones that we missed, maybe that could be a future conversation. Right. Yep. There's a whole network in the Sandhills that are doing telepsychiatry that the trust just funded, I think, to put telehealth equipment into 20 practices. A lot. I mean, so it's growing out in a lot of different ways.
And the problem is, Jeff said, not none of this where we can leverage each other's strengths.
Right. And maybe coordination isn't good at some point, you know, like, I'm not sure there's any central group that like, oh, I got the ideas. You know, this is an idea generation thing, and this is about innovation. So the coordination is really about spreading ideas and figuring out maybe some of these basic questions, like how can we help with sustainability or policy development. I mean, that's the coordination activities we probably need, is how we can undergird the innovation and spread the innovation and make sure that it's going to be successful in, you know, accomplishing these improvement. I mean, we're really about, all these ideas are about improving health of a group of people, our population.
Josh, maybe you get the last word. Or you and Skip can share it.
I'll have to cite the last word. Cashews. Because I've never been in a room with hundreds before, I would just encourage whoever, whatever it is, whether it's state or private foundation, please fund people, not the equipment. We get equipment, we get funders coming from full grants and everything else. Yes, you need to, more importantly, coordinate those programs, collaboration, and exchange. Last but not least, I think I would encourage you to acquire, of course, collaborate if possible. Want truly profitable time, setting the grant. If someone wants your money, just sorry, hospital.
Okay, Skip, last word, really.
The other observation is that nearly all the things we're doing across the state are already well-established and far into the trajectory. We need to be thinking creatively about how to use technology much earlier about preventive applications.
Okay, thank you all very much for your time. Thank you to all the speakers and the ones on the phone for coming. Also, let's have a round of applause for Delvon.
Thank you. You're welcome to come anytime Jay can't. Well.
Yeah, he's the important one, no doubt about it. Okay, so we're gonna.
Yep, we'll flip into this. Well, wait, I'm going to give out this phone number. For those on the line, I'm going to give you a phone number. If you want to dial this next, this will be the number to dial into. It's 877-594-8353. And your dial-in code after that, after you dial the phone number, is going to be 853-04922. So if you dial that after we hang you up here and you'll come back in on the same phone, but just a different route.
Great.
Thanks.
Thank you.
Bye.
Thank you.